My job is a little different today. I'm going to talk to you about something different, which again it's not new, and a lot of people are talking about it. I'm going to talk to you about collagen cross-linking, and Rishi gave a nice buzz to it, zap the bug. We know that the microbial keratitis is definitely a public burden, and there are a lot of cases occurring in our society. And not only that, the treatment cost itself is no less. The treatment lasts quite a long duration, and a lot of these antibiotics, whatever we give, sometime may not work, finally leading to resistance because of many more reasons and many methods or mechanisms. But what happens along with this thing is also bad surface. It damages the surface, it leads to a lot of toxicity on the surface, and finally if we do a corneal transplant like Dr. Somshila showed, that a lot of time they do not survive also. So is there an alternative treatment to this thing? Is there something else we can do? Well, there seems to be something lurching at the horizon that's called PAC-CXL, or which is called photoactivated chromophore for infectious keratitis. Basically, this is a little different from from the keratoconus treatment. Hence, to differentiate it, it's called PAC-CXL. What we do? Why to choose cross-linking? Well, we know that since almost 2000. The plasma sterilization has been done using riboflavin as well as ultraviolet rays, and before transfusion these things are sterilized using these photochromophore, and so it's not new. There are in vitro reports which actually claim that it can take care of most of the organisms including fungus. Also, there are reports which claim that it actually takes care of a lot of organisms, and some of them do claim that maybe it's probably not the best for the fungus. Now, all these reports does prove that actually there's something happening to these organisms, and there is a potential that we can probably try them in vitro or in patients rather. The lab studies done at LVP also showed that it works in multi-drug resistant organisms also, and however when we treated them with fungus, for the fungus and acanthamoeba, the outcomes were not so great. So what is the mechanism of action what we are looking at here? Well, in simple words, we are doing two things. One, we are fortifying the stroma. We are making the stroma a little strong so they do not get digested by the collagenylysis which occurs because of all those endotoxins. And same time, we are increasing the apoptosis of those organisms by creating those nascent oxygen or free radicals which are generated by collagen cross-linking treatment. So in laboratory and in theory, well, it can work. There are reports which now shows that it actually works in patient also, and there is enough article or literature support which shows that it has been tried in most of the organism. There are certain interesting things also, like in RP Center they reported that not only it works in some of the organisms, when we do the treatment, it prevents much of a vascularization also, which is also very interesting. So when can you use them? Well, whenever we have a microbial keratitis which is not responding to the routine treatment to the duration which you feel is enough for the treatment, where the lesions are a little more anterior-stromal and probably where you have potential of next therapeutic graft, but you want to reduce the vascularization. The procedure is simple, same as what we do for collagen cross-linking, but rather than what Rishi was suggesting, flash cross-linking or high fluence cross-linking, it's better to do a low fluence cross-linking, as in 3 milliwatt for 30 minutes rather than 45 or 30 or 18 on those things. The logic behind this thing is lower the fluence, longer the duration, deeper the penetration. Hence, if you use very high fluence, the penetration is much more superficial. Hence, the treatment remains a little more superficial than the deeper. We did our own studies and we found that out of our 16 patients, the bacterial keratitis which were in 11, out of 11 we had 8 resolution, successful resolution. 6 fungal keratitis, out of that 3 showed resolution. Acanthamoeba, one of the acanthamoeba keratitis resolved but came back again. Now, different from the previous studies, what we included were, most of them were very severe keratitis. So I deliberately didn't put up in the indication that it can work only in a very small lesion and all those things. Well, it may work in bad lesions also. However, please remember, it does not work in every possible thing. Another interesting thing which we saw was that the post-operatively pain was quite less. It's like a photogenic denervation what we achieved by reducing the sensitivity of the nerve. Patients were much more comfortable. Also, a lot of them, those who didn't have hypopion, got hypopion. This was very interesting. Why should anybody get hypopion? And then we found in the literature, well, this is something what we were taught in our microbiology, Jeris-Hexheimer reaction, where because of the sudden death of so many organisms, they lead to liberation of those endotoxins, and which leads to formation of hypopion. So hypopion per se may not be just bad in such kind of cases. So one such case, as you can see here, quite severe non-healing bacterial keratitis, had gram-positive organism which was grown on culture also, was treated with collagen cross-linking of PEG-CXL, and 8 weeks you can see the resolution. Similarly, one of the fungal keratitis, again quite deeply seated fungus, and filamentous fungus Aspergillus flavus, was treated with PEG-CXL and showed a resolution, a significant resolution at 7 weeks. Fungal keratitis, apart from the fungal keratitis, acanthamoeba is one more nemesis. We did treat with PEG-CXL acanthamoeba. It responded earlier, but again recurred later on after a few weeks. It doesn't mean that everything you probably can zap with PEG-CXL. There are certain cases where nothing works and probably ultimately end up in the therapeutic corneal transplantation. Now there are enough articles and literature, and in fact there is one good meta-analysis available about all these literature, which shows that, well, it has a potential role. It can work in a lot of cases. However, you have to be selective in your case selection. Also, there's something interesting which has been published, which is called window absorption or cross-linking without doing the debridement of the cornea. Here what they did, the authors did not debride the epithelium. They let the cross-linking, let the riboflavin percolate through the small epithelial defect which was there in microbial keratitis. They used hypotonic solution, and so that to swell the cornea also, and they found interesting results. Also, there are some articles which show quite a large number of cases and showed that they did a good amount of sterilization with this thing. If you put all the literature together, interestingly, most of them showed almost a resolution from like 80% to 100%. Well, because we took larger cases, or rather more severe cases, that the resolution rate in our case was almost 55 to 56%. The neo-treatment, well, neo-treatment could be something where you can do the treatment on slit lamp, and which should be there probably within a year or so, where you can do collagen cross-linking on slit lamp, not only in cases of keratoconus, but also in cases of microbial keratitis. But at the same time, there are certain issues which are standing up. Like some people have reported that moxifloxacin resistant following cross-linking. Well, we tried such kind of thing in our lab, but we were not successful, that we could not induce any change in the sensitivity pattern. But well, there may be a potential of such thing. Also, there are reports that when we do cross-linking, there is loss of keratocytes. So keratocyte loss probably may not be the best thing in healing pattern. So we really don't know whether this will affect our immune system to take care of the microbial organisms, especially when they are not taken care by our cross-linking or the treatment of the drops. So we really don't know what's there in future, but definitely there are long-term studies required, and future studies will definitely clarify the role of this new modality of treatment. So as of now, PEG-CXL could be a new way of treating microbial keratitis, especially when they are not responding to the routine treatment. The lab studies and clinical studies They do show that the treatment may work. However, it may not work in everything. The treatment seems to be effective in bacterial keratitis. However, there are reports of fungal keratitis also responding, but definitely that would not be the first line of treatment. The PAC-CXL again seems to be more effective in superficial treatment, but please remember, do not go ahead with accelerated cross-linking. If you use a regular cross-linking, probably it may work in deeper cases also. So finally, we still have miles to go before we get the final solution. But as of now, it seems to be very interesting treatment. Thank you very much.